Hi, I'm Pat Iyer, and this is Legal Nurse Podcast. Today, we're going to be talking about a topic that affects your analysis of medical records because of the frequency with which you will find cases where patients have gone to an urgent care center or an emergency department if they're more critically ill. I brought on the show Katie Patel, who is a nurse practitioner. She's a legal nurse consultant. She's an expert witness, and she has clinical experience in cardiology and urgent care. And Katie is working with me now in the LNC Academy as we build her coaching, as we build her LNC practice. Katie, welcome to the show.
Thank you.
I know that your experience has been in urgent care in the past, as well as you're currently working in urgent care. What are the kinds of typical services that an urgent care setting provides?
Well, an urgent care can provide, and it will vary between locations, but in general, they will provide basic medical services, and almost every urgent care will be able to provide x-ray services. We can do point of care testing, strep tests, mono, things like that. Some urgent care centers do offer CT services or ultrasound, and those are rare. There aren't a lot of standards right now as to what an urgent care has to provide, so it's going to be variable between different types of facilities.
Mm-hmm. And because we have listeners from at least 72 countries, I thought it would be helpful to pull back a little bit and say, what is urgent care? What does that mean in the context of where we function in the United States? That may be a concept that could be completely different in another country or not exist at all.
Sure, and actually I think even here in the United States, some people aren't quite clear on what an urgent care is for or does. So in general, an urgent care is a separate walk-in clinic that is open hours beyond typical physician offices. And we would offer care for something that you might see as a same-day sick appointment for your primary care doctor, but your primary care doctor can't accommodate you on that day. Or, simple fractures, sprains, things like that. We do not provide emergency services, and that's a pretty distinct difference between an urgent care and a freestanding emergency room. They're becoming more common as well. If you're having chest pain or stroke symptoms, those are not reasons to come to an urgent care because we can't help you with that.
And I know that this type of care is called different things, and maybe there are nuances. I have seen, for example, signs that say nurse practitioners have an office in Walmart, for example. You could walk into Walmart as a large supermarket slash department store. It's hard to describe Walmart to somebody who's not familiar with it because it's such a phenomenon, but you could buy your groceries and your screws and see the nurse practitioner all in one visit. So
you could, yes.
Tell us about how care is spread about when it comes to the urgent care concept that we're talking about.
So the types of clinics that are located in a Walmart or in a lot of large national retail pharmacy chains, we refer to those as either a convenient care or retail care. And they typically provide about a step less of urgency than an urgent care would. So they can do things like your basic sore throat, look in the ears, sinus infections, those types of things. They wouldn't be able to do additional procedures like incision and drainage for an abscess or take x-rays in order to diagnose a fracture, things like that.
Okay, so that's convenient care. And then we've talked a little bit about urgent care, and then you mentioned freestanding emergency departments. What is that all about?
So the freestanding emergency department is a newer phenomenon, and I'm in Missouri, but we see these more on the coast right now, and they involve the full care that an emergency department could give you. However, they are not located within a hospital. So they're completely off-site. They're typically open 24 hours a day, and they typically staff an ER physician. That's the recommendation, at least. And they can provide full ER services, including any other diagnostic imaging, basic lab work, and those types of things.
I think I've seen signs for one when I've gone to Miami. There's a big pole, and at the top of the pole, it gives the name of that freestanding ER, and it says, wait 17 minutes. Now, what is that about? Telling people who are driving on the highway the number of minutes of waiting time they might have if they go there. Is that an accurate number in your experience?
It's a marketing strategy. They are advertising, hey, come in and we'll get you taken care of quickly. But in any true emergency service or any walk-in clinic, it's pretty hard to estimate a wait time because 6 people can walk in the door at the same time. And that happened to me yesterday.
Did it?
Yeah, so if you're the first person in line, you're going to be seen quickly, but if you're the 6th, it's obviously going to take longer.
Mm-hmm. And I'm assuming, Katie, that you run into situations in urgent care where people walk in who are not appropriate for that setting. Is that a big part of the sifting and the sorting that goes on, or the triaging at the beginning of the visit?
It is. And, I'm not necessarily the one up front always greeting the patient or there when the patient arrives. I could be in the back doing something else. So we do rely a lot on our ancillary staff to kind of help us screen things that we may need to eyeball quicker. Additionally, in an urgent care setting, we are not bound under EMTALA laws, which for those out of the country, those are laws that govern emergency departments and basically allow for a patient to have a medical screening exam and receive care regardless of the ability to pay. So in an urgent care setting, we don't fall under those guidelines, and we can turn patients away, recommend a higher level of care, or, depending on the policy of the specific urgent care, you don't necessarily have to see you if you cannot pay up front.
So you can turn away a poor patient or an indigent patient from urgent care because of not being bound by, is it the Emergency Medical Transfer Labor Act? I'm thinking about Treatment and Labor Act, yes. Which came about because of a pregnant woman, and I think she was in Texas, who was sent by ambulance to another hospital down the road while she was in active labor because she didn't have a source of payment, and then ended up delivering and having a catastrophic outcome while she was en route from one place to the next. And that stimulated the government to say, hey, we can't just keep turfing away or sending away people who can't pay.
Absolutely. And, unfortunately, in an urgent care setting, we don't fall under that. And that brings up an interesting point about different types of urgent cares, because they can be associated with large hospital systems, but there are a large amount that are privately owned. So these are for-profit clinics, privately owned, and are there for a bottom line. So, I personally would never send somebody in an emergency situation just out in the parking lot. I would take care of them and do the best I could with calling an ambulance, etc. But there's different clinical policies that vary between each clinic that you're bound by if you're an employee there.
Where does that poor patient go?
Well, unfortunately, most urgent cares will give you the opportunity to prepay. So if you have the money to prepay upfront, regardless of insurance status, then they will take care of you. Other than that, it depends on your local resources. So for example, I'm in St. Louis, and we do have clinics that work with you on the sliding scale, those types of things. Or if you're a Medicaid patient, we can refer you back to your primary. Or unfortunately, a lot of times they end up going to the emergency room, because in the emergency room, they will not be turned away for their ability to pay.
So we talked about some financially inappropriate patients, and I almost hesitate to use those adjectives. But medically inappropriate patients are another big category of who's walking through your door, being carried through your door. We had a man in my church who was diagnosed with West Nile fever this summer and was so ill that he could barely hold his head up. When he got to the urgent care center, where he said, listen, he said to his wife, listen, I'm not that sick, but she could tell he was so sick. They looked at him in the wheelchair. He couldn't even walk out of his car. And they said to him, look, you have a choice. Either your wife drives you to the hospital, or you get an ambulance to drive you to the hospital, which was fortunately on the same property, where he was admitted and he was diagnosed with this disease caused by mosquitoes that had bitten him. Tell us about, other types of people who are not appropriate for urgent care.
Well, and a lot of times it can be a gray area. And so patients truly don't know if they're appropriate and tend to prefer urgent care because we're faster. And so they'll come in for things. For example, I had a patient yesterday who came in, and it was a similar situation. She had difficulty getting out of the car, and we have at that specific clinic, a large amount of windows ahead of us. So we could see her being unloaded from the car, and I got my interest right away. And she was elderly. She came in complaining. Her first statement was, well, first I called 911. So that got my attention also. And her complaint was severe onset of leg pain, along with her leg being cold and blue. So I just said, I need to stop you right there. And this isn't the appropriate place for you. I cannot do anything other than an x-ray and feel your pulse. So that patient definitely was a good referral to the ER. But we have patients that come in with stroke symptoms. I've had a patient in active labor before come into the urgent care, and that one was an ambulance transfer to the hospital because she was getting way closer than comfort level for delivering. We had a wide array of things. Typically, it's things like a severe infection, maybe a severe cellulitis that possibly needs a lab workup and IV antibiotics. Those sometimes we can see in the urgent care, but what will happen is if you're registered, you're going to be billed for an urgent care visit. And if I have to refer you to the ER, you're going to get a bill from both places. So we try hard to screen those patients up front to the best of our ability.
You mentioned having ancillary staff in urgent care, and I know that you're a nurse practitioner. What are some of the types of medical professionals who work in that setting?
I've worked in clinics that have registered nurses supporting the physician or nurse practitioner. Currently, the locations I work with, we have a radiology tech and a provider, so either a physician, a nurse practitioner, or a physician's assistant. And really, they function as all the support staff in one. It's pretty amazing. There's some clinics that use medical assistants or LPNs, and so it just really varies based on the location and the amount of volume that you have.
And I'm assuming there's no standards that say you have to have a certain number of certain types of people available in that setting? Is it purely discretionary as to who is used to staff that urgent care setting?
It is. There are no national standards, no minimum standards, and each clinic or each like large organization may come up with their own standards for it. And so I worked in a variety of privately owned and hospital owned locations, and it varies a lot between those types.
A legal nurse consultant gets a set of medical records involving a patient who went to an urgent care setting, as an example. How is the legal nurse consultant to be able to make some judgments about whether the appropriate level of person saw the patient? And by level, I'm referring to the background of the person who saw the individual, which of course encompasses from the moment the person walks in, was this patient effectively triaged, sorted out, and told, no, you need to go to the emergency room, versus we think we can handle you here. And then who does that individual, that patient, see once he or she is in the door?
That's a very good question. Now, as far as the provider goes, you're usually staffed by nurse practitioners, physician's assistants, or physicians. And those physicians can be trained in family practice or emergency medicine, typically, in my experience. So the way that a nurse practitioner or a PA is trained, it's going to depend a lot upon their clinical background and what they're comfortable with. And so it's going to depend very specifically on that specific provider as to whether or not they are going to be able to meet those standards of care or really provide a high level of care. There are a lot of clinics that will take nurse practitioners that don't have emergency experience or NP experience. And then there are some that will require you to have X amount of emergency experience or years of nursing, and it'll really depend upon that. And then even within that, you could find an excellent nurse practitioner or PA that doesn't have a lot of clinical experience too. So it really just depends. As far as the staff that will greet them, most places will have some sort of a protocol for high acuity complaints and a process for notifying the provider. So if a patient comes in saying, I'm having severe chest pain, most places will have a protocol in place that they stop, they go and find the provider and go from there.
And I shared with you an experience that my husband and I had at an urgent care center outside of San Francisco, with a setting that had a physician's assistant who also had a PhD. His lab coat said PA, PhD, and the staff referred to him as the doctor. And I thought it was a little slick to call him a doctor. He was a doctor, but he wasn't an MD. My husband had an insect bite on his leg that got quite swollen, and the doctor said, I should put that in quotes, said, I'm going to give you an antibiotic ointment, but he prescribed a cortisone ointment. And I don't think he knew that I was a nurse. And of course, he never knew that I had been involved in legal nurse consulting, and I was watching everything that was going on, including the 2.5 hour wait that seemed quite long compared to what I was expecting. And my husband got better, and the cortisone ointment was helpful and the swelling went down. But it brought up something that I've run into in my family practice office also, of calling physicians, assistants, and doctors when they're not. My husband had, in our family practice clinic in New Jersey, had a PA introduce himself as a doctor, and my husband knew the difference. My husband is sophisticated, and he's gotten even more sophisticated, having been married to a nurse for 49 years. And he spoke to the family practice doctor and said, look, your PA is calling himself a doctor. And that stopped pretty quickly. So as we think about who's staffing the urgent care setting? I think that's one thing for our listeners to be aware of what are the credentials of that individual, and is there a level of supervision that's required? Like, for example, is there a physician who's always looking over the shoulder of a PA or a nurse practitioner, or are those individuals always functioning independently, or does it depend upon the state what level of supervision is occurring?
Well, it depends upon the state. I am in Missouri, and we are actually the most restrictive state in the United States for nurse practitioners here, which is unfortunate for our patient population because it just limits more access. But I do not have a physician present in the clinic with me. Our current law is that the physician would review 10% of the charts that I complete. And this is after a 30-day collaborative period in the beginning of our collaborative practice together. And so those are the guidelines here. Those are pretty restrictive, but in many states, their nurse practitioners can practice independently. Actually, in Missouri, they've recently passed legislation moving for physician's assistants to practice more independently even than a nurse practitioner at this point. So my NP colleagues here, we have some work to do. But there is not necessarily a physician always overlooking what a nurse practitioner or physician's assistant does. I do agree with you, though, that I think it's very misleading for there's nurse practitioners that have PhDs or doctors of nursing practice, and that's a pretty hot button issue on referring to yourself as a doctor in a clinical setting because it's misleading to patients, and the patient deserves to know who's treating them.
I know that you've been doing some expert witness work. Tell us a little bit about the liability issues that crop up in urgent care settings.
So urgent care is a relatively new specialty in the US, and it's been around, but it's really grown explosively within the last 10 years. And so we're starting to see more and more complaints come about that involve urgent care providers or patients that have at some point been to an urgent care. Currently, the level of claims are mirroring about what we see for family practice or primary care practice in the amount, but we're seeing patients that are visiting urgent cares for more and more serious complaints, and we're seeing a push for not transferring as many patients to the emergency room, and so in there becomes a gap of patients that may have a more serious condition that's appropriate for urgent care, and those are the types of complaints that come in.
So it sounds like what you're describing is if you put this on a continuum, there are some very obvious urgent care complaints that belong in that setting. And then they travel on the continuum up towards the gray area of, is this appropriate for urgent care or is this appropriate for ER? And you're identifying claims that occur in that gray area, if I understand what you said.
Correct. That definitely that. And there's complaints that do belong in urgent care. You know, say you have your patient with a sore throat and their strep test comes back positive, and that's completely appropriate for an urgent care. However, without a good physical exam, you know, you may miss a paratonsillar abscess, which is an emergency and should be transferred to an emergency room. And so things like that, things that may masquerade as very simple complaints, but have a more serious undertone to it. And that's where urgent care providers need to be very vigilant in order to avoid bad outcomes for their patients and then litigation.
Do urgent care centers experience the same stresses that doctors' offices do in terms of getting the patients in and out and in and out and in and out as quickly as possible?
Absolutely. That number is tracked very closely in any urgent care I've worked in. And the time for the patient between the time that they walk in the door to the time they see the provider and the time that they walk in the door to the time they walk out the door are very important to the administrators in urgent care. And so those are definitely things that are tracked, and we know they're tracked. And as providers, we're typically evaluated on that also. And so it's in everybody's interest that we keep things moving as quickly as possible.
That means then, as the practitioners, they have to be astute in their physical exams. They have to come up with quick diagnoses. I can see the liability issues pile up related to that pressure.
Absolutely. And that in a way can make it more difficult for a provider to be working in an urgent care setting versus an ER setting, where still those turnaround times are important and checked, but you also have lab work and imaging to fall back on to help you diagnose it. We don't have that in urgent care. We have to use our physical exam skills and excellent history taking skills to get a big picture of a patient very quickly. It's obviously not somebody we've seen before and may not have access to all their medical records. They may not be an excellent historian. So we have to be pretty good at reading things out and listening for those red flags.
I think you're identifying some of the pitfalls of that setting, of the pressure, which we call production pressure,
Mm-hmm.
and then not having a lot of technology at your disposal, and having people who can't always clearly give you a good history. Are there any other pitfalls that you think influence the liability in an urgent care setting?
Most definitely. There's the lack of follow-up for a patient. And so if something needs to be seen again in 24 or 48 hours, and the patient doesn't have a primary care physician, that can be a big pitfall. Or the patient that may not be reliable and may not follow up appropriately. It's a gray area as to setting specific follow-up for a patient. For example, eye complaints are something that I almost always recommend seen between 24 and 48 hours by an eye doctor. And if the patient doesn't have an eye doctor, that can present a problem with the continuity of care. Again, if the patient has a problem 2 days later and comes back, I'm probably not the provider working that day, and so they're going to be seen by different people every time they come into the clinic. That's not a good substitute for primary care. And again, the discharge instructions need to be very, very clear for patients that outline the specific follow-up and also reasons that they may need to go to the emergency room, or reasons why things may be outside of what we would expect for their course of illness. And that way they can take control of following up. But if it doesn't specifically state that, saying that you told the patient that is probably not going to fly in a deposition or court.
You have pre-printed discharge instructions available for common illnesses or injuries?
We do. In most places, we do. Currently, in the system I'm working with, we can actually type in specific instructions for that patient too, and it becomes a part of their medical record. I find that really handy because then there is a record of what I gave them.
Mm-hmm.
I've written things on patients' discharge instructions also, but I find for tracking purposes that to be not quite as helpful.
So if we pull back and we think about the trends, you've identified that urgent care settings are mushrooming in terms of numbers. Do you see that litigation is going to increase in urgent care settings, types of cases? Is that your expectation?
I do. I do think that we will see an increase in types of litigation against urgent care providers. We know that there is a trend of increasing litigation against nurse practitioners, and this is mostly due to the growing number of nurse practitioners, not because the care is insufficient. And so as there are more opportunities for bad patient outcomes and issues to arise, we're going to see more of it.
You make me think about when I first started identifying different types of expert witnesses that I needed to supply to attorneys. At first, I had a general category called nurse practitioner. By the time I sold my company, I think there were about 20 different subcategories, from neurosurgical to obstetrical to internal medicine to critical care to emergency department, and the list went on, because of the number of cases against nurse practitioners kept increasing.
Yes.
And the specialization kept increasing as well.
Yes, and I think that will continue because nurse practitioners are growing at rapid rates, the amount, and patients are going to come in contact with them more, which increases the risk of litigation.
So Katie, thank you so much for being a guest on the show. I know that 30 minutes went by really quickly. How can our listeners find out more about what you offer?
You can visit my website, and it's kpmedlegal, and that's medlegal.com, or you can email me at katie.patel, Patel, at kpmedlegal.com.
And Katie is an expert witness. She also provides legal nurse consulting services in addition to being an expert. Thank you so much for sharing your expertise, Katie.
Thanks for having me on, Pat.
And the takeaways I think that I have gotten out of the show is, if you have the need to go to an urgent care setting, to think about, is this the best environment for you, which puts a burden on a patient, but we as nurses have that advantage. We've talked about appropriateness of the setting. We've talked about different levels of providers who are in the urgent care setting, and that the fact is that the technology that exists in an emergency department does not exist in urgent care, which puts a greater burden on the urgent care practitioners to use their senses and their history taking to determine what's wrong with the patient, and then can they come up with a treatment plan that's going to be appropriate for that setting. And as Katie mentioned, what's the follow-up going to be once that problem has been diagnosed? Not everyone has primary doctors, so they may not be in a position to go back to a family practice doctor, and they may come back to the urgent care center to be checked, and chances are they won't see the same person who took care of them the day before.
Absolutely.
Well, thank you, Katie, and thank you to you, our listener, for being part of the show and spending your half hour with us as you're walking the dog, driving the car to work, cleaning the house, working out in the gym, whatever you're doing while you're listening. We thank you for being part of our show and soaking up the wisdom that we have to offer in this podcast. We'll be back next week with a new show, and be sure to tell other legal nurse consultants about Legal Nurse Podcasts so that they can benefit from the guests that we bring onto the show. And this has been Katie Patel and Pat Iyer.